Okay.
Yes, now I can see.
You can see?
Yes, I do.
Oh, I'd like to start. Oh, hello, everyone. My name is Masaru Sasaki from Japan. I'm very happy to be able to speak to you today. I'm a dentist and work at a general dental clinic. And today I'll talk about oral cytology, especially about oral liquid-based cytology for early detection of oral cancer. I'm sorry that my presentation is not concerning breast cancer. In Japan, the number of deaths from oral cancer and pharynx cancer increased threefold in the last 3 decades. Sorry. This is an inconvenient truth. Last year, an impressive event happened in Japan. A famous popular singer announced that she had advanced tongue cancer. When she was aware of a small ulcer on her tongue, she consulted a physician and a general dentist. But for about 6 months, they were unable to diagnose her tongue cancer. When she visited a cancer specialist, her tongue cancer had already advanced to stage 4 with lymph node metastasis. She lived in the central area of Tokyo. Unfortunately, oral cancer is sometimes not detected in early stages even in central Tokyo, where the healthcare environment should be the most enriched in Japan. As you know, clinical causes of advanced oral cancer are not good. After graduation from dental school in 1986, I was trained in the Department of Oral Surgery at the Tokyo University Hospital. At the time, a lot of advanced oral cancer patients visit the hospital. But even now, almost half of oral cancer patients visit cancer specialists in advanced stages in Japan and maybe in the rest of the world. In this slide, this slide shows the 5-year survival rate of Japanese tongue cancer by stages. In stage 4, it is about 50%, but it is but in stage 1, about 95%, and in stage 2, about 80%. Moreover, in the early stages, dysfunction after surgery is mild, and its cost for medical care are lower. Early detection will greatly affect the patient's chances. What is the effective way to early detection of oral cancer? Patients with such mucosal lesion shown in this slide sometimes visits our general dental clinic. But it is possible that early stage oral cancers are hidden. Moreover, general dentists may notice mucosal lesion during treatment for tooth decay, root canal treatment, and regular maintenance of periodontal disease, even when the patient is unaware. Actually, this one case is an oral cancer in early stages. In my opinion, it is very difficult to diagnose this case only by visual inspection and palpation. So general dentists need a new device for early detection. So new device. For the cervical cancer, cytology is used for early detection. This picture is the father of gynecological cytology, Dr. George Papanicolaou. Oral cancer, the same squamous cell carcinoma as cervical cancer, account for about 80 to 90%, but oral cancer is not common. A conventional oral cytology is called brush test, started in 1990s in the US. But conventional oral cytology needs many skills and a lot of time for training to make fine microscopic smear specimen. In my opinion, it is very difficult to make reliable smear specimen for a general dentist. Moreover, moreover, as you know, during the process of conventional method, many collected cells are discarded. But liquid-based cytology, LBC, improved this one, effectively utilize collected cells, and almost all collected cells are examined. Generally, the amount of squamous cell epithelial cells collected from oral mucosa is considerably smaller than that of the cervix. The reason is that oral mucosa is constantly falling off due to the mechanical forces of food, toothbrushes, and things like that. So LBC has an advantage, especially in oral cytology. About LBC system, SurePass and SimPrep made by global maker are very common. SurePass by BD used a density gradient quantification system, and SimPrep by Hologic use filter system. LBC Prep by Japanese domestic maker used basically a density gradient quantification system. This is a specimen of oral LBC process by SimPrep for our patient. In this way, general dentists can make fine microscopic specimen. This paper is a study comparing the ratio of inadequate specimens, the sensitivity and specificity between the conventional methods and LBC in oral cytology. The result shows that LBC method had fewer inadequate specimens. The percentage is 12.4% in conventional methods and 8.8% in LBC. In a study, the definition of adequate specimen is determined by collecting basal, parabasal, and intermediate cells. I'd like to point out a higher percentage in inadequate specimen than gynecological cytology. In gynecological cytology, the definition of adequate specimen is determined by the number of collected squamous cell epithelial cells, but in oral cytology, it is determined by the depth of layer in which cells were collected. This is largely due to the difference between the biological nature of cervical cancer and that of oral cancer. In oral squamous cell carcinoma, well-differentiated cells are often found in surface layer, but early invasion may be found in deep cell layer. Actually, the accuracy of cytological diagnosis of oral HCC greatly depend on the sampling depth. Therefore, a swab is not suitable as sampling tools for oral LBC. Previously, we have used side brushes or interdental brushes, but at present, in my personal view, the Orthorex brush developed by the Robert company, the Netherlands, is most suitable for oral exfoliative cytology. It is made of the same materials as a cervix brush, and the shape of the tip is designed to collect cells in the deep cell layer of the oral mucosa. In summary, these are the advantages of oral liquid-based cytology. 1, simple technique for general dentists. 2, fewer inadequate specimen. 3, standardized fine specimen. For early detection of oral cancer, the role of general dentist is very important. Oral cancer screening devices for general dentists need to be simple technique. Oral LBC don't need complex techniques, so every general dentist can perform this examination without hard training. And for cytopathologists, standardized fine specimen are needed for a correct diagnosis. Therefore, I believe that oral LBC is a useful examination for early detection of oral cancer. Concerning the cytologic grading system of oral exfoliative cytology, in 2015, Japanese Society of Clinical Cytology established the first cytologic grading system in Japan. In Japanese grading system, adequate specimen had 5 categories: nil, low cell, high cell, SEC, and IFN. We have performed oral liquid-based cytology in our general dental clinic since 2013. Among 99 examined cases, 2 cases were diagnosed cytologically as SEC class 5 and also diagnosed histologically as SEC. And 1 case was cytologically diagnosed as low cell class 3, and then he was diagnosed histologically as SEC in the consulted Tokyo University Hospital. This is the first case performed oral LBC in a clinic. 18 years old male. This case was obviously diagnosed clinically as tongue cancer. 50 by 45 millimeter size ulcerative lesion with bleeding and induration were found on the right side of his tongue. Oral LBC shows that basal, parabasal, and intermediate typical cells, these cells show the high NC ratio and nuclear hyperchromasia. A few superficial atypical cells showed abnormally configured keratotic cells with orange-colored cytoplasm. In high-power field, light green color atypical deep layer cells show the irregular nuclear membrane and dense cytoplasm. So this case was diagnosed as squamous cell carcinoma SCC class 5. At consulted Tokyo University Hospital, this case was diagnosed histologically as SEC, well differentiated. Next case, we could diagnose cytologically as early stage 1. 70 years old male. The clinical diagnosis was soft palate ulcer, not specific. 10 by 8 millimeter size small ulcerated lesion with slight bleeding were found. Induration was unclear. The clinical diagnosis was not specific ulcer. However, in oral LBC, basal, parabasal, and intermediate typical cells showed high NC ratio and nuclear hyperchromasia. A single light green colored atypical deep cell layer, deep layer cell showed irregular nuclear membrane and dense cytoplasm. So this case was diagnosed as squamous cell carcinoma SCC class 5. At the consulted Tokyo University Hospital, he was diagnosed and was also histologically as SCC. Next case. Next case was cytologically diagnosed as low cell in a clinic. 70 years old male, clinical diagnosis was tongue cancer suspected. 20 by 15 millimeter size ulcerative lesion with bleeding and induration was found. In oral LBC, superficial or intermediate cells showed the nuclear hyperchromasia. These cells showed abnormally configured keratosis with orange colored cytoplasm. Few single orange colored atypical cells show irregular nuclear membrane and dense cytoplasm. So this case was diagnosed as low cell class 3. This patient was referred to the Tokyo University Hospital and performed histologically examination and diagnosed as SCC. We could diagnose with a patient as C2 in a clinic. We usually refer the patient diagnosed cytologically as low cell, high cell, and SCC to cancer specialist. Next case was suspected gingival cancer clinically. 70 years old male, clinical diagnosis was gingival cancer suspected. 18 by 50 millimeter, 18 by 15 millimeter size deep ulcerative region with induration was found on gingiva. On oral LBC, many superficial keratinite mature epithelial cells showed a low NC ratio and numerous neutrophil predominant inflammatory cells could be seen in the necrotic background. Orange colored keratinite superficial cells and light green colored intermediate cells showed low NC ratio. So this case was diagnosed as Nerum class 2. After full denture conditioning treatment, his region got better soon. Finally, I'll comment concerning the pitfall of limitation of oral LBC. The cytological diagnosis of oral SCC greatly depends on the sampling depth. Therefore, the case with thick keratotic surface layers, it is difficult to diagnose early invasive SCC. For example, such white region with thick keratotic surface layer, oral LBC is not suitable. So we should perform incisional biopsy. This is a summary. I believe oral LBC is the most useful devices for the screening of oral cancer for